Hello, this is Dr. Rajni Mundal from Pathology Watch, here with your 3D 3-minute digital dermatopathology digest. Today's topic is squamous cell carcinoma. Squamous cell carcinoma is a malignant squamous proliferation, most commonly due to chronic solar damage and mutations in p53. This is one form of squamous cell carcinoma known as squamous cell carcinoma in situ. This is a malignant squamous proliferation involving the epidermis. You can see here full thickness keratinocytic atypia with lack of maturation as you go from the base to the top. There is increased cell density, increased nuclear size, and variation in nuclear size and shape. As you go to the top, sometimes in the periphery of squamous cell carcinoma in situ, you have atypical keratinocytes present as single cells that invade and involve the adjacent normal epidermis. This is known as pagetoid spread. Many times, just in the same biopsy specimen, you can have invasive squamous cell carcinoma. Invasive squamous cell carcinoma are typical keratinocytes that are present as nests in the dermis. The level of keratin differentiation is important, and this is denoted by eosinophilic cytoplasm as well as keratin production. You can characterize squamous cell carcinoma as well, moderate, or poorly differentiated, dependent on the amount of keratinization present. This is one form of well-differentiated squamous cell carcinoma, known as a keratoacandoma. It is defined as having rapid clinical growth and resolution. You can see here there's a keratin-filled crater, and surrounding the keratin-filled crater are atypical keratinocytes. Very commonly, these have a glassy cytoplasm. And sometimes you can have neutrophils involving the atypical keratinocytes as well as trapping of elastic fibers. Multiple KAs are seen in the syndromes of Grabowski, Ferguson-Smith, and Smithmuratore syndrome. Here is a poorly differentiated squamous cell carcinoma. Poor differentiation, thickness of greater than 2 millimeters into the dermis, invasion of the subcutis, and lymphovascular invasion are high-risk features that denote a poorer prognosis. This is more common moderately differentiated and well-differentiated squamous cell carcinoma at the top, and you can see here a proliferation of cells in the dermis. These cells have amphiphilic cytoplasm and no distinct keratin production. This is poorly differentiated squamous cell carcinoma. Here are your 5 flashbacks for today. Squamous cell carcinoma is a malignant squamous proliferation due more commonly to chronic solar damage, immunosuppression, HPV infection, chronic injury or scars, and exposure to arsenic or carcinogens. Mutations in p53 and p16 are more common. High-risk clinical features include size greater than 2 centimeters, location of the ear, lip, and central face, presence of elderly or immunosuppressed individuals. The in situ component is full-thickness keratinocytic atypia involving the epidermis. Invasive is nest of malignant squamous cells in the dermis. You can have well, moderate, or poorly differentiated tumors. High risk includes poorly differentiated, thickness greater than 2 millimeters, invasion into the subcutis, and lymphovascular invasion. A keratoacandoma is characterized by clinical rapid growth and resolution, a keratin-filled crater, neutrophils, and elastic fiber entrapment. Multiple Ks can be seen in Grabowski, Ferguson-Smith, and Smithmuratore syndromes. That's it for me for today. This is Dr. Rajni Mundal from Pathology Watch, revolutionizing pathology for dermatologists. Check us out at pathologywatch.com.